Welcome everyone to today's program. I am Robert Kurtz, moderator for the webinar. The program will begin with a roundtable discussion between our panelists, and then we will have a question and answer session following completion of the roundtable. You can submit any questions you have throughout the webinar by typing them into your control panel in the space labeled "Enter a question for staff" and clicking send. Our panelists will attempt to answer as many of your questions as they can during the Q&A portion of the program. It is now my pleasure to introduce today's panelists. We have Blayne Rush, President of Ambulatory Alliances. He is an SEC registered and FINRA licensed investment banker. He specializes in ASC brokerage, ASC turnarounds and increasing ASC valuations through physician recruitment and syndications, and access to the capital markets and capital structuring consulting for surgery, urgent care centers, and radiation oncology centers. We also have Kurtz Bernstein, Managing Director for Sinaiko Healthcare Consulting. Kurtz specializes in providing valuation, transaction advisory, strategic, and operational consulting services to clients. He has extensive expertise working closely with hospital systems, physician groups, ASCs, and other healthcare providers. We will now begin the roundtable. I'm going to ask Blayne to start the discussion on my first question. Blayne, what do you see as a typical pricing of deals today?
Thanks, Rob. You asked what is most people's number one question first, which is good, but before I get into answering that, I want to thank you for moderating this discussion. I want to thank Kurtz for lending us his expertise, and I want to thank each participant for taking time out of their busy schedule to listen into our discussion. But when speaking about pricing, most people's default is to discuss it in terms of multiple of EBITDA, which obviously is earnings before interest, taxes, depreciation, amortization. But my disclaimer always is that in reality the devil is in the details, because we can influence EBITDA, and we will not get into that here, but we can cover that in next month's webinar. Okay, since I've disclaimed everything that I'm about to say, when we look at pricing, we typically break it down into two main categories. One is control equity interest, and one is non-control ownership interest, which is also referring to majority ownership and minority ownership. And when we refer to control and non-control, we're talking about that in the financial sense and not in the clinical or business decisions. But the purchasing price, the lowest purchasing prices that I've seen for functioning centers is about 2.5 times EBITDA. We've gotten some lately in the 5 times EBITDA range, with the bulk of the transactions being in about 3 to 4 range. There's some instances when the purchase price has been less, but that's for centers that need turnaround or centers that went dark, and then that's really when asset value comes into play. When buyers or investors look at potential deals or investments or purchases, they look at the potential deal through risk lens. The riskier the deal that the investor sees, the lower the price will be, and obviously the lower the risk, the higher the offer will be. There are some tools that we can use to mitigate or lower the risk to the buyer, but we're not going to cover that right here. But whenever majority interest purchase prices come into play, the lowest that I've seen for a single surgery center compared to, say, like multiple centers or a chain of centers is 3.5 times. The highest that I saw last year was 9 times, with the majority about 5 to 7 range. And the 9X was a single specialty pain center that actually had a significant amount of out-of-network business. The buyer was a very motivated financial buyer, where this was their first healthcare transaction. And in that situation, the strategic buyers were coming in somewhere in the 3X to 4X range.
Kurtz, do you want to add any thoughts to that?
Yes, Rob, thank you. As Blayne said, I appreciate everyone taking the time out of their busy schedule to join us today. I think the question is the typical pricing, and my response is there really is no typical pricing because every deal varies. There's a lot of stuff to consider in a transaction. How many physicians are currently owners? What are the different specialties? What does the outlook look in the market? Does the center have a certificate of need? Are there multiple centers, as Blayne had mentioned? And we hear a lot of people speak about the typical 5 to 7 times EBITDA range at a lot of these conferences. But as you know, as we'll discuss with our next question, which is around pricing, that I'll get to in just a second here. With regard to the fair market value standard, you can consider different things that a control buyer might be able to do with a center. For example, if the center has continually negotiated poor managed care contracts, you might be able to bring in a better manager. That just a controlling shareholder would say, hey, I can get in a manager in here with more experience dealing with managed care contracts and improve the revenue of the center. That might be able to increase the price of the overall center as a multiple of historical earnings. You might be able to cut down on some expenses from the control perspective, increasing that multiple as a compared to historical EBITDA. You know, most buyers are looking at historical EBITDA. Sometimes you might want to look at adjusted EBITDA just because of the significant changes that could possibly be made to a center. So every center is run differently, and I don't think there really is a typical pricing, and there's definitely a wide range of pricing as a multiple of EBITDA out there.
Thank you, Curtis. Before we move on to the next question, Blayne, could you give a basic definition of EBITDA for any of our listeners or any of our attendees who aren't familiar with the term?
Yeah, the term is earnings before interest, taxes, depreciation, amortization. So you got to add back the interest, taxes, depreciation, and amortization whenever you're figuring the number out.
Thank you. Next question I'm going to direct to Curtis. Curtis, can you speak to how are prices determined?
Yes, well, it's very typical in a surgery center to have physician ownership. I've never ever seen a surgery center without physician ownership, and as a result of that ownership, any price that is paid to purchase a center is required to meet the fair market value standard under the anti-kickback law. Now, I'm not an attorney, so we won't go into too much of that, but we can define what fair market value is. As I said, it's required under the anti-kickback law or statute. It considers a hypothetical willing buyer and seller. It's an arm's length transaction. It's what's known and knowable at the date of transaction, and may take into account any improvements that can be obtained by a hypothetical buyer, which is something I mentioned on that last question. With regard to healthcare, we have a very unique industry because of the fact that different buyers can get paid different amounts to perform the same service. You know, so if you perform a colonoscopy in your ASC, you may get paid one thing, but if your physician performs that same colonoscopy in the ASC down the street, they may get paid something different by a managed care payer, just because that center's been able to negotiate different rates. So it's very hard to define a hypothetical willing buyer and seller. You know, it might be hospitals in the market, it might be management companies, it might be other doctors, and there's a wide range of buyers out there. And we try to define the market through those hypothetical buyers and understand what all the buyers are able to achieve, as well as their expected rates of return, the rates of return within the market. And I know Blayne's going to talk a little bit more about the difference in rates of return between a new buyer of a surgery center, maybe one of their first acquisitions, or a company that hasn't bought a surgery center in a while that needs the increase in same-store sales. What the other definition of value you may hear out there is investment value, and the difference between fair market value and investment value is you're no longer considering a willing buyer, but you're considering a specific buyer. So in this case, you take into account synergies that are specific to the buyer. For example, the buyer may have centralized billing. It may have the capacity to handle the billing of this new surgery center. If you specifically consider that capacity, that would be investment value. Whereas knowing that a center has too many billers in it already, and the hypothetical buyer might come in there and say, we don't need 5 FTE billers, we only need 4, and making that reduction in your analysis, that would be fair market value. Your better managed care contracts, you can't look at specific contracts of the buyer. You know, we get into this a lot in hospital deals where the physicians will come to us and say, hey, the hospital gets hospital outpatient department rates where ASC rates are 59% for Medicare as a percent of hospital outpatient departments. Well, those rates are specific to a hypothetical. I'm sorry, those are specific to a hospital buyer and not the hypothetical buyer in the market. What we could do is we could look at better managed care contracts overall. You know, if a surgery center is earning at the 10th percentile of the market for managed care reimbursement, and we look at we have a paid claims database of paid claims in surgery center settings. You know, we may say that it's a very good chance someone will come in there and be able to negotiate better rates. The other standard of value that Blayne talks about more in the the investment side is the market value, and the market value really is just the value that results from the auction of the business on the open market. So if you bring in buyers and have them compete against each other, what is the ultimate value? What is the most you can get for that center? And it's where you have willing buyers compete against each other, and they're willing to offer amounts up to only a certain amount of return. And obviously, all that transaction is done at arm's length. So the market value really is not a premise of value as defined from the valuation perspective, but it's kind of more in line with reality of what goes on in the market. And there should be some tying between fair market value and market value in a sense, because you have the same hypothetical buyer, then what rates could be negotiated within an open market. It needs to have some sense of reality between the two different definitions.
Thank you, Curtis. Blayne, do you want to add anything to that?
Yeah, whenever we go out and visit with the buyers, a lot of times what they're looking at in the specifics of the surgery center that's for sale is say, hey, physicians, do you have a significant number of physicians and physician mix in cases? And is there potential for growth for that specific surgery center through syndication, recruiting more physicians and cases? Because if you're reliant upon only a few doctors in their cases, they view that with a great deal of risk, and it's not as attractive. Therefore, people will be offering less money. How many centers are the physicians investors invested in? If these guys or girls, for that matter, are invested in multiple centers, and those centers are competing for the same cases, they also view that as risk. The assets, hey, will the buyer have to invest in new equipment or not after they come in? The amount of interest that's sold, we spoke about that a little bit a few minutes ago. Is it a minority interest or a majority interest? What does the competition in the area look like? So how many ASCs are in that same geography? Are the hospitals that are nearby buying up ASCs? Do they have some now? Or are they looking at your surgery center as a potential add-on for those guys? Is it located in a CON state? Like Curtis said, what do the managed care contracts look like? If you have strong payer contracts with long-term dates, with good reimbursement, they look at that in a favorable light, while they don't look at out-of-network. Most of the buyers look at out-of-network as very risky in the sense of reimbursement risk. Then they also, the financial markets, how available is debt? What does the capital markets look like? So can someone go out there and get a lot of money easily, and that will drive up price? Just look at the residential housing markets, if you will. Whenever anybody with a heartbeat could get a loan, obviously the prices for the houses were up, and when the availability of those loans went down, then obviously the prices went down. But all those are the science answers behind that. What's not spoke about much is, hey, what is the motivation of the potential buyer? Who needs the deal at today in this point in time? How many people are bidding on your center? How many? Who has the money to spend? who has use it or lose it money. Some buyers have money that they have to say, hey, we have to spend it by a certain amount, a certain date, or they'll have to give that money back. So essentially, who's hungry for a deal, who's trying to show growth on their balance sheet because they're preparing to go public. We've seen buyers out there that are looking to go public that are buying some centers that most other people would shy away from because they're looking to show that growth. So anyway, that's whenever we go to market. So those are some of the things that the buyers are looking for.
Thank you, Blayne. I'm going to keep with you for the next question to kick us off here. Who are the typical buyers and what are they looking for in a center?
Well, the typical buyers are historically consistent. You have physicians and physician groups. You have ASC management companies, so they're the national chains, regional chains, local chains, if you will, hospital, health systems, and then you have the private equity groups. Obviously, all of them are looking for a situation where they can increase their investment. Physicians and physicians groups, which the things they're looking for that are different a lot of times than what some of these other buyers are looking for. Sometimes they're looking for a tool. Hey, where can I go to bring my cases that I can get block time that's easy for us? Those guys sometimes will buy these one OR rooms. ASC management companies, sometimes they're looking for is obviously to be able to grow that center. Say that you're at 65% capacity, so they look at that attractively versus, hey, I'm at 85, 90% capacity. Well, unless they're looking to buy cash flow, which isn't too often the reason that they're going in there and buying that center, they typically shy away from those. While hospitals might look at and say, okay, the surgery center is at 85, 90% capacity because they're getting some ancillary value from buying a center that has a lot of physicians and are at that capacity that they can bring the inpatient beds and whatnot. And then the private equity groups, obviously they're doing it for a financial gain. The reason that there's not more private equity groups investing in single surgery centers is that they look, to come in at the minimum EBITDA at about $1.5 million. Some will go lower than that, but if they're going to buy, typically if they're going to buy a single surgery center, they're looking to create a platform company, so they'll buy a surgery center, and then they'll turn around and try to add on other surgery centers, so they'll have a package or a chain or multiple surgery centers that they can sell, say in 5 years. They'll sell to a strategic buyer, which is in this sense, typically an ASC management company, or they'll sell to a larger financial buyer, which is a private equity group.
Thank you. Curtis, you have any additional thoughts?
Yeah, you're probably getting a sense I don't like the word typical because I don't think there really are typical buyers. To Blayne's point, we're seeing a number of management companies out there now. There's been some consolidation within the market, obviously, like NovaMed and Surgery Partners joined together. We're seeing some other smaller companies join together as well, but there's still a significant number of management companies out there that are looking for deals, and they're looking for different things. The management companies that are not public might be willing to do a little less than a 51% interest. What you have to remember from a public company is they're looking for the consolidation. If they get control, they can consolidate the cases into their financial statement, which shows growth, even though they don't have that minority interest right down on their income statement. And as Blayne said, you have companies that are looking for same-store sales growth. You don't think of it like a retail shop, but it really is. You need to continue to show growth through case volume and through revenue, and that's why with the changes in Medicare, a lot of the surgery centers that have the orthopedics and the general surgery and the specialties that really benefited from the Medicare really went for higher multiples, because at the end of the day, as their reimbursement went up, you can show same-store sales growth. which is really what private equity groups are looking for, and the private investors within public companies are looking for. Really have that's really all I have on that question, because I'll save the rest for the next one with management companies.
Well, thank you. Let's move right into that. Curtis, going to have you start a discussion on typical deal. Is it with a management company buyer or a hospital?
And like I said, typical. There's nothing typical. With the public companies, as I was mentioning with the consolidation, we're seeing that public companies not really do deals with management companies. We're seeing those systems like the tenants, the HCAs, the community health systems go out and want to buy the center. They want a controlling interest because they want to consolidate the entities. We are seeing hospital and management companies joint venture. They might do a health system 51%, management company 49%, buying a 51% interest in a surgery center, or the management company had an interest in the surgery center, is now bringing in the hospital partner. We're seeing that more on the not-for-profits because they're not as worried about the consolidation issues, and we are seeing a number of those ventures coming together. I've heard, and these probably all need to be verified, but like HMA and ASCs doing a joint venture, and Catholic Health Initiatives and Surgical Care Affiliates, and USPI and Catholic Health West. So there's a number of those different ventures out there that are looking to buy centers. They may buy 51%. Some of them are willing to buy 30%. They're generally looking for a decent interest in the center, but there's really no specific amount that I've seen. With regard to the hospitals, I'm looking to buy a percent that they might be able to get the hospital outpatient department rates. They might buy 100%, and then we're seeing a move toward these co-management deals, especially if a management company is involved, where the management company may remain a part owner with the doctors and may co-manage the surgery center. So this table right here just gives you a basis of kind of how the co-managements are formed. They'll generally have a group, and they'll get a base fee for managing the center, and then they'll get a certain portion of incentive payments for meeting certain indicators, whether it's quality or operational or whatever, as the center performs in the future. On the next slide, I think we show kind of a little bit of a structure of a co-management. Your typical, the joint venture side is the ASC management company and hospital come together to create a management company, which would joint venture with the doctors. The other one is the hospital, and sometimes the hospital and the management company coming together with the doctors to create a management company which manages the department. And we're seeing a definite shift in there, especially since you already have all the physicians together within the surgery center, so that company is already there that can be the manager of the surgery center into the future. But just so everyone's aware, I mean, any of those management fees that are going to continue to be paid out to the prior owners probably needs to be considered in the upfront payment, because that's going to affect the overall return to the buyer. If on a go-forward basis, there's additional monies coming out of the center. It may not if the center's already paying the management fee to a management company. So it really depends on the specific deal and how it's structured.
Thank you, Curtis. Blayne, you'd like to add anything to that?
Yeah, like Curtis said, it's very dependent upon the deal, meaning the specific deal, and then sometimes the location. As he was referring to, there's some of these large management companies that have created these exclusive arrangements, if you will, with some regional health system. For instance, the Dallas area, USPI and Baylor, the way I understand it, that USPI cannot do a deal with a surgery center unless Baylor is involved, and vice versa. So you have all those little pockets around the U.S. that if you look to sell to one of those entities, then they're going to be involved with a hospital for sure. So that's about, I mean, he covered it pretty well.
Thank you. Blayne, we're going to stick with you for starting us off in the next discussion on this question of how intent do you see chains are in bringing in hospital partners?
You know, with the hospitals employing a lot of these physicians now, obviously that's the big deal now, and obviously that was the big deal back in the 90s whenever I grew up in healthcare. There's more, we're seeing more of these ASC management companies looking to bring on hospital partners for that reason, and also for the contracts. A lot of these management companies, for the most part and generally speaking, are scared of the out-of-network models and whatnot, and these hospitals typically are able to get better contracts than some of the individual surgery centers and some of these chains. So I think that some are very intent, meaning the ones that have majority ownership, and then you have the other spectrum that whenever they have minority interest, they're probably not as likely, or that's what, as far as the deals that I've been involved with.
Thank you. Curtis, you want to share any thoughts?
Yeah, I agree with Blayne. I mean, we've been seeing a strong push across the country to employ physicians. We've been actively involved with health systems employing a number of primary care groups, from solo physicians to multi-physician groups. You know, we were involved in one not too long ago where the health system bought a physician group of 240 physicians. So, you know, we've seen a lot of that in the primary care. We've seen a little in the specialists with cardiology and oncology, which obviously doesn't affect the ASC space as much. But really the primary care, which is the gatekeeper, you know, to a lot of the cases, are going to become employees of the health systems. And we've been hearing a lot of talk. We haven't seen it so much. We've seen it in limited fashion around other specialists, which would affect ASCs. We've been involved in a couple of deals lately where health systems have bought some pretty decent-sized orthopedic groups. And obviously, if the orthopods are becoming employees of the health system, they can direct where they want those cases to go. So it's kind of one of those risks that you take, not being involved with the hospital. But if you are able to get the hospital involved, I think ultimately the companies are thinking that they can work with the hospitals to continue to keep the cases at the surgery center, because the surgery center is a low-cost provider out there. So I think there's pretty significant intent in trying to get involved with the hospital systems as much as possible, while still keeping things independent as long as possible.
Thank you. We touched a little bit on out-of-network in that last discussion, so Curtis is going to have you speak to the question of what do you see as the prospect of selling a center that's heavy out-of-network, and a little more about how are buyers valuing out-of-network centers.
Yeah, so I mean, a couple of the management companies out there have their whole strategies around out-of-network. So I think it's definitely possible to sell an out-of-network center. The issue is you're not going to get the same multiple of earnings as you would for an in-network center, just because the strategy of an out-of-network center has definitely been tested recently in various states. It's been tested pretty strongly by Blue Cross in a number of states. I've seen cases recently in California. I've seen cases in New York. And while I don't think any party truly won any of those cases, I think they all settled. It just goes to show you that the payers are going to continue to push down on paying out-of-network rates that are significantly higher than in-network rates. So when we value a center, you know, we're going to look at the state and see the pressure that's been on out-of-network reimbursement within that state. We're going to and probably take some kind of adjustment associated with the risk that revenue may not be around for long. With regard to management companies and private equity and these publicly traded companies, it goes back to same-store sales. I mean, ultimately, if you buy an out-of-network center and tomorrow the insurance company, the payer says, we're not going to pay you those rates anymore, we're going to pay you a lot less, and obviously you can litigate it and probably settle, and you'll settle somewhere in the middle. But the point is that tomorrow those same-store sales are going to drop 25%, let's say, maybe 50%, depending on the extent of out-of-network that you have. And this question says heavy, so if it's heavy, it definitely is an issue. And that right there, from a market perspective, like if you're looking at the stock market, and someone says our same-store sales dropped 25% this quarter because all our payers are paying us in network now, well, that's a reduction in cash flow, and that's a reduction in gain to all your investors, and you're probably going to be facing some pretty heavy lawsuits from your investors. So everyone's concerned about same-store sales, and out-of-network strategy, would affect your ability to continue to grow that, and it's a high risk that those will go down in the near future.
Thank you. Blayne, your observations?
Yeah, I've been involved with preparing and bringing to market and selling some out-of-network centers, and one of the biggest challenges is that your buyer pool shrinks significantly, and it really depends on the risk tolerance of the potential buyers. Some are well established at a certain point where they want to sell or go public or whatever. They're unwilling to take on that perceived risk. Out-of-network has been, there's been talk that that's going away for a long time now, and I've seen some ASC that they're completely out-of-network and they continue to grow and continue to be profitable. So it's a challenge to some buyers, but like I had mentioned early on, there's some buyers that are willing to take on that risk. Some will mitigate the risk in the sense that they'll discount the purchase price, and that's what the majority of them will do. I've also, interestingly, have seen recently what they're calling out-of-network contracts. What does that mean? Well, some of these third-party contractors are negotiating with these out-of-network heavy ASCs to lower their price, but it's nowhere near what they're paying the in-network ASC down the road, meaning it's significantly more. And so they go on, some of these third-party payers are going to this out-of-network contracts where they're coming in and trying to mitigate their risk in their payer contracts. So I'm seeing more of those, but it is a tough world to go sell out-of-network centers, but you just have to go to market and see if there's some new buyers coming into the market that are willing to take on a little bit more risk. And whenever they look at that and they assess the center that's for sale, like Curtis said, they're going to look at the state. Texas in particular has been more friendly to out-of-network. There's been some laws that were passed that make it easier for out-of-network centers, but then there's some states, like Curtis said, that are is very tough on those types of centers.
Thank you. Next question is, how much of a concern is it to see partners that have an ownership interest in more than one center? Curtis, I'm going to ask you to start a discussion on this question.
It can be a concern. I think it depends on how much of an interest those partners have in your particular center. Where the other center is located. Sometimes it's a decent amount of miles away where it doesn't make sense to take patients to that center that are in one market versus the other market. It depends on what kind of returns that doctor is getting from your center, and so long as you can maintain a good working relationship with that physician, it's probably okay. Sometimes there's just certain doctors that are hard to get along with, and any kind of change might make them blow up and just use the other center. I mean, they're not always restricted to use your center just because they're an owner. I mean, they can go use the hospital patient department or the center down the street if they get upset over something. So, a couple factors, just reiterating, how much ownership do they have? How locked in is that doctor into your center? What's their overall attitude like? And is it pretty easygoing and friendly, and they get along with the folks in your center where a small thing might not might not make them upset and move them over to that other center. It's also the location of the other center. Blayne?
Yeah. When the buyers come in and do their due diligence, that is something that they look at significantly, because obviously they're investing a significant amount of money, and they're worried about after they pay these physician owners, if you will, which is typically the process, they are going to move that business somewhere else. And so they'll look at and see how many surgery centers they're invested in, but they will offer more for centers that these doctors are only invested in that center. And some markets that doesn't happen too often. Dallas market, a lot of these surgeons have investments in multiple surgery centers. We're lucky to find, I'm working with one right now, that the doctors that bring the most cases, this is the only surgery center that they're invested in, and they have the non-competes that would prevent them, meaning that their office is right up there, from investing in some of the other surgery centers. But like Curtis said, they could still bring those cases at other places that they're not invested in. So yes, it's a concern for some buyers. It's just they're going to look at, hey, how many surgery centers are in the market, how many are they invested in, et cetera.
Thank you. Blayne, keeping with you, next question, do you see more or less interested buyers competing for deals than you saw a year ago?
It depends on the deal, and what I mean by that is the deals that are very attractive, those are hard to come by. So all of the buyers are looking, even the minority interest investor buyers and the majority interest investor buyers, they want to look at those deals, and those, because all of those competing bids are driving those prices up. But whenever you start looking at the out-of-network deals, the potential buyers are going down. Whenever you look at the single specialty 1 or 2 OR that has 1 or 2 docs, the potential buyer pool for those deals are going down compared to times in the past.
Curtis, could you share your observations? Yeah, I think like Blayne said, it really just depends on the surgery center that's available for sale. I've heard from a lot of management companies and health systems that they have a lot of money and are ready to buy, and are out there looking for deals. So we're seeing a lot of buyers out there. We're seeing people be pretty aggressive on going out there and trying to get deals done. The difficulty is finding a good deal. Finding a good multi-specialty surgery center where the doctors are all locked in. They're still going to do their due diligence. They're going to do deals that make sense to them. So, ultimately, from my perspective, I'm still seeing a lot of buyers out there that are looking for deals, and if the right deal's out there, they'll do it.
Thank you, Curtis. Next question, we've touched on this a little bit, but I was hoping, Curtis, have you lead discussion a bit more on whether you're seeing multiples going up or going down.
Yeah, pretty much seeing them stay the same. I wouldn't say they're really going up or down. I think companies are paying the same multiple on a surgery center based on the specifics of the surgery center. A good surgery center, like Blayne said, he saw one go for 9. I might see him go for a 10. I might see him go even a little higher than that, depending on the growth prospects and stuff like that. But I think he would have gotten that same deal last year or the year before for that same center. I don't think the expected returns have changed. I don't think the access to capital has changed. I do see more people out there looking to do deals, or I guess not more people, but just more people saying they have money now and they're available to do deals. So I think you're going to get the same multiple that you would have gotten before based on the specifics of the center. But every center is different.
Blayne, could you discuss what you're seeing?
Yeah, I think I agree with what Curtis is saying, except for the very attractive deals. I think people are willing to outbid some of the other buyers because there's just not very many of the very attractive deals. The ones that have great payer contracts, that have a good mix of physicians and physician specialties that have great markets, CON states, etc. There's just not very many of those deals. So you have a significant amount of money, like Curtis was saying, that there's a lot of people wanting to buy centers, and some of those guys will say they'll just go for it and buy a center that they might not have bought in the past because there's not as many centers available in their target, if you will. And so we're seeing that the multiples on the top end are clicking up a little bit compared to the past because there's more competition for those centers.
Yeah, and I'd like to just quickly add to that. I mean, we're also seeing more hospitals out there looking to buy 100%, and you probably weren't seeing that, 2-3 years ago. The hospitals really weren't the buyers out there, and they weren't looking to buy the 100%. So you're probably seeing a little bit more on the multiples for the 100% go up too, because from the management company perspective, for 100% buy, it doesn't make a lot of sense because you're going to buy at a 7 multiple and then have to re-syndicate at a 3 multiple, and that'll obviously bring down your overall return. So you probably pay more like a 5.5 multiple for 100%. Well, with the hospitals out there, everyone buying 100%, I think it's probably driving up some of those multiples, for 100%, where you wouldn't have really had a buyer for 100% before.
Thank you. Second and last question for our roundtable. Blayne, I'm going to have you start a discussion on this one. Someone wants to sell their center. Can you describe what the typical sales process is, timing-wise, from conception to closing, and what, if anything, a seller can do to speed up the process?
Right. Thank you. It depends on how many parties are involved in the deal. What I mean by that is, hey, if you have 3 physician group, ortho group that are close and on the same page, etc., then it would probably be less timing. And if it's going to be sold to, say, a management company or one party, be it a management company or a hospital, you're probably looking at, if they're not well put together, you're looking at 9 months, 6 to 9 months. Some of these deals with complex parties where you have 15 physicians and you have a management company and a hospital, so it's a 3-way deal. I mean, they can take 12 months. I've seen some that you had to go in there and clean a lot of things up, take as long as 18 months. So short as 3 months, meaning when everything was teed up, all the way to 18 months. Some of the things that you can do to shorten that time frame is to be prepared. There's essentially what I would call stage 1 and stage 2 due diligence that these buyers want to see before they even say, okay, that's something that I want to buy. And then they'll come in, obviously, and do a lot deeper to validate those stage 1 and stage 2 due diligence. But if you have all of that done, if you have all of the partners and the potential sellers all on the same page, and then you have your process organized and you manage that process, then you're going to be able to shorten that time frame.
Thank you. Curtis, you have anything to add?
Yeah, I think Blayne summarized it pretty well. I mean, the other side is really the availability of data and the sophistication of the seller. I mean, sometimes the sellers are unable to provide data. We see this in evaluation all the time where, the electronic systems aren't up to speed and you can't get data out of the systems and you can't find operating agreements or any of that stuff. So that, it makes sense to kind of get all your ducks in a row before you even go down the process and make sure you have all the information. And, that'll even help your multiple in the end, because if the seller sees that you have everything managed nicely and correctly, then ultimately they're going to consider that as part of their deal.
Excellent. Thank you. Blayne, going to have you lead us off on the discussion of this question of what issues are you seeing of particular concern to buyers today?
Yeah, I think the largest issue, and we've touched on that earlier, is the employment of the physicians. And whenever you start seeing orthopods being employed by the hospitals, then we all know it's moving towards that direction, because those are typically high-paid surgeons in the market, and typically they are the ones that hold out. I haven't seen as much as what Kurtz has referred to, but one of the largest, again, is the physicians being employed, and then the out-of-network. They come in there and really look at that closely, and the majority of them, whenever I go to market, will say they're not even interested if it's a significant amount of that out-of-network, because the traditional seller isn't willing to discount the price enough where those potential buyers would be interested in buying that center.
Thank you. Over to you, Kurtz.
I think Blayne covered a lot of that. Really, what are the biggest concerns? We covered a lot of it in a lot of the other questions through diligence and making sure they understand that the overall operations of the center. What are the growth potentials? What's the capacity like? How much the owners own of the center? Do they own other centers and all that? So I think a lot of this has probably been covered with the other questions.
Excellent. We'll now transition into the Q&A portion of the program. We'll try to address as many questions from attendees as we have time for. If you'd like to submit a question now, you can do so by typing your question into into the control panel on your screen, and in the space labeled "Enter a question for staff," and click Send. If we don't have an opportunity to get to your question, or you have other questions or feedback, definitely encourage you to contact our panelists directly. Their contact information is on this final slide. Certainly encourage you to reach out to them. Again, if you have follow-up questions or we don't get to your question, please certainly contact them directly. We're also going to be regularly hosting these business-related type webinars. If you have any suggestions for topics, definitely reach out to them. You can reach out to me as well if you have any suggestions or thoughts. Let's get right into the Q&A. First question, I'm going to direct this one to have Kurtz start us off. Do you feel it is necessary to get an outside consulting firm to do a quote-unquote formal valuation of the business? In particular, how the valuation then affects the price of any new doctor who would like to become an investor?
Yeah, Rob, I think that's probably a bad question for me. Maybe we should direct that to Blayne. That's mostly what I do is valuation work. So of course you should get it all the time. But no, but in reality, obviously you're required to do the transaction at fair market value under the anti-kickback statute. So there are some legal requirements. We are able to do some limited scope type valuation work when there's less risk. If there's a hospital involved, while ambulatory surgery is not a designated health service under Stark, a lot of our hospital clients are worried about the indirect referral relationship with the doctors, because they do refer inpatient cases and generally want more of a higher scope valuation done. But overall, I think it makes sense to get it done as part of the deal. You have to do it right at the beginning, not necessarily, if you work with someone like Blayne, he's making a market and there's a number of buyers out there and it's arm's length, and I think you have a lot of stance in which you can provide support that what you did was fair market value. We've actually seen writing from the OIG that says just because you have a valuation report doesn't mean your deal was done at fair market value. Obviously, some of the buyers, like the health systems, have other reasons they want to buy, and that may not make the overall transactions arm's length, and that's really when you get the valuation firm involved. Is if you want kind of that other insurance policy, and it depends on who the buyers are. There's lesser risk with anti-kickback when it's physician-to-physician deal, because you're not always getting the urologist referring to the orthopods. The internal medicine doctors aren't involved here. The primary care doctors aren't involved here. So you may not have as big of an anti-kickback issue in some deals. Some deals you may have more. Some deals you may have indirect Stark issues. And, I leave that really open to your legal counsel, how comfortable they are with the deal. And if you involve someone like Blayne, obviously you're making a market, and that should be pretty consistent with fair market value at the end of the day, because that's, the market, fair market value, the most important word in the definition is market, and it's what would this surgery center sell for in a hypothetical transaction in the market. And Blayne, just as an example, is making that market, and that kind of defines what the price should be.
Blayne,
anything to add?
No, I think you're fine. The only thing I would add is, hey, it really goes back to what does your governing document say. If it says, hey, a predetermined formula, then obviously use that predetermined formula. If it says at fair market value, then you have to answer that question. Do you want to take the conservative approach and hire a valuation expert to provide that for you? That might be a good way to go.
Excellent, thank you. This next question is directed to Blayne. Blayne, you and Curtis spoke about some of the sciences behind how a center's sales prices are determined, and you spoke a little bit about some of the other keys that are not as scientific, that were more of the art of the process. Can you help this attendee understand how you know who has the use it or lose it money you mentioned? How do you know what management company is going public? How do you know who has a strategic need for a center in a particular part of the country? All these questions that give insight.
Yeah, good question. Value is for a specific point in time, and your center is worth as much as somebody's willing to pay for it. And if you're looking to maximize your value capture in the terms of the deal, and to be able to answer all those questions that you ask, what you'd have to do is what investment bankers call a broad auction approach. Essentially, you go out there and try to figure out, who are all of the potential buyers and buyer types in the marketplace today, and then you have to go and prepare your center and go market to all of those guys at the same point in time, and then solicit the bids and negotiate the bids, etc. Because the only way that you're going to know, hey, who's doing this or who's doing that at this particular moment in time is to go to market and cover the market as broad a sense as possible.
Thank you. Next question I'm going to direct to Curtis. Curtis, are you seeing any sort of trend of hospitals purchasing single specialty surgery centers? And if so, what benefit would a single specialty ASC offer to a hospital beyond ancillary income?
I really haven't seen too many of those deals. I've heard of a couple recently, but haven't been involved in that. Ultimately, I'm not sure that ASCs really provide anything else to the hospital. Obviously, it's a low-cost provider of services to the market. They're managed a little better. Doctors can have their block time and easily manage their cases. Hospitals can move maybe some more of their outpatient cases out to the ASC. It depends on where you're located. If you're in a CON state, the hospital may not have the CON for an outpatient center, and it's easier than going through a CON process. So ultimately, they get that center, and they can move some of their ophthalmology cases, for example, or GI cases out to that center and free up some of the capacity within their outpatient department. There's obviously a lot of benefits to a health system to buy a surgery center other than just the income. They do get the HOPD rates on the cases that are already there, so from a Medicare perspective, it should increase reimbursement. I've heard a lot of talk, and all it is talk. There's no meat behind it, but a lot of people have been saying, well, ultimately that difference between HOPD and ASC, or HOPD and physician fee schedule for like the nuke meds and the EKGs or the chemotherapy or any of the specialties that are being bought for physician practices will go away, because it just doesn't make sense for Medicare to keep paying it as everything becomes part of a hospital. So there's definitely a lot of benefits out there for a health system.
Blayne, would you like to add anything?
No, I think he covered it pretty well. I don't know that I could add anything to it.
Okay. I have another question that might be loosely related to this. Let me know if there's anything else you'd like to add. The market, do you see any market for a single room ASC physician-owned surgery center, and how can such a surgery center market itself? Blayne, any thoughts?
Yeah, that's a tough market. Okay, the potential buyers would be physician or physician groups that would want to utilize it as a tool. I'm assuming that based off of the description of what you just said, that that's essentially what the current owners utilize it for. Or, you know, conceptually you could look at surgery centers that are at or near capacity in the area that could move some cases there and expand a little bit more. That's a potential market. Or the same scenario with a local hospital health system. You know, someone that is at or near capacity and just needs a little more space.
Excellent. Curtis, any thoughts?
No, I think Blayne covered that pretty well.
Okay, I got time for a couple more questions, and then we will conclude. Either of you, we'll start with Blayne on this. You seeing many surgery centers performing surgery on the weekend, and how would that, if any way, impact the value of the center?
Well, where we see that is, or more so than others, is some of this elective surgery, because you're looking at the buyer, if you will, the patient has a choice of when, where, how, etc. So you're seeing that more so. We are working with some surgery centers that do some ENT cases and some GI because they're just trying to go out and capture the patients that would go somewhere else if they weren't open on the weekend. You know, whenever they value them and whenever it refers to the valuation, they're going to look at that similar to all the other valuation techniques and the way they do it as what we've covered before. I don't know that that's going to, what day that the surgery is done is going to influence the valuation or the price very much, if at all. They're going to look at all the other and just kind of bring it in as if it was done no different than Monday through Friday.
Curtis, would you like to add anything?
No. I mean, Blayne covered that pretty good. I guess the only thing I could add is with regard to capacity. You know, if you're already doing cases on the weekend, chances are you're getting pretty full on your capacity for total cases, which may affect you overall from ability to grow. It depends on, you know, that also depends on your center and your space. Obviously, you can add additional ASC space, or maybe you have some room to build out minor procedure rooms, general operating rooms, or whatnot. But it would definitely be something to consider overall with regard to the capacity of the center.
Thank you. I'm going to ask Curtis and Blayne to provide some final thoughts in a moment, but first we're going to get to our last attendee question we're going to have time to get to today. How common or uncommon is it for you to see a non-provider or a non-provider group want to invest in an ASC, and why would this type of investor be attractive to the owners of an ASC, if at all? Curtis, any thoughts?
Sorry, Rob, did you say a non-provider group?
A non-provider or a non-provider group. Is it common to see someone like that interested in investing in ASC, and would such a person or group be attractive to a surgery center?
I mean, ultimately, I'm not sure what we mean by a non-provider group. I mean, for example, management companies are, I guess, fall into the category of non-provider group, and you know, they bring certain things to the table. You know, you obviously have to do your diligence on the buyer as well. You know, the big things management companies might be selling is access to a GPO or access to better managed care contracting negotiation, hopefully bring in some higher managed care rates. The other obviously big thing we're seeing is pay for quality across the country, and they bring certain EMR systems that allow you to track quality or compare your quality versus other other centers within their network and have best practices on how to improve quality at your center. So there obviously are some benefits that are brought by those buyers. You might have a very well center that really can't benefit from any of that, so maybe there isn't. So it's definitely important to do your due diligence on your buyer as well. There's other physician non-providers like anesthesiology. I think we were talking about briefly before. They obviously bring something to the table. They're part of your business. You need them to be happy. You need them to be available. Otherwise, you can't do your surgeries. So it might make sense to get them involved in the ownership as well.
Blayne, any thoughts?
Yeah, a little bit I could want to mention is anesthesiology, like he said. I've been involved with some of these groups that, anesthesiology groups that have an interest in providing management to some of these surgery centers. And a couple other things that those in particular, they're typically at the head of the table with all these other surgeons. So they know who is recruitable, and they have a lot of deep relationships with these other surgeons in the marketplace. So in that type of situation, that could be beneficial to a current ASC owner to bring in the anesthesiologist if they're going to do this, this, and this, however you define that. But as far as them being non-productive, they don't bring any of those other intangible assets to the table, then I'm not sure why you'd want them to invest.
Excellent, thank you. For any attendees, if we didn't get to your question, you have any follow-up questions or feedback, again, I encourage you to reach out to Blayne and Curtis directly. You can certainly contact me as well. My email address is on this final slide. I want to give our panelists an opportunity to share some final thoughts before we conclude. Curtis, why don't you begin?
Sure, thanks, Rob. I think this overall was a good webinar. There were some great questions, and hopefully everyone had the opportunity to get in the questions they wanted to ask. There's definitely a great market out there for surgery centers still. Like I said before, there's a number of buyers who have told me recently they have a lot of money to spend and pretty aggressive strategy to purchase surgery centers across the country. It makes sense to work with someone like Blayne who can help bring in the right buyers. He knows who's out there and what they're looking for, and could obviously generate the greater return. And from the fair market value standpoint, I think fair market value needs to be in line with reality and what willing buyers are able to pay for the surgery centers that are out there based on the current economic environment we're in.
Thank you, Curtis. Final thoughts from you, Blayne?
Yeah, I appreciate it. Want to just thank everybody again for attending, and to remember, like Curtis has said over and over again, that there is no such thing as typical, and some of the pricing and EBITDAs that we have spoke about are really heavily dependent upon the deal. And as Curtis said, there's new buyers coming into the market yearly. There's a couple of new buyers now that they say they entered into the market probably about 10 months ago, and they still have not purchased a surgery center. They've hired staff to go out there and market and whatnot, and they have money that, and how they term it is hungry. So they want to go out there and find the right deal that fits within their strategy. And as I've conveyed to those guys, that sometimes they have to buy their way into the marketplace, and depending on what you want out of the deal, that's a potential partner for some of these surgery centers that have a little bit more risk.
Excellent, thank you. Well, it's been a pleasure for me to moderate today's program. I certainly want to thank Blayne and Curtis for a great roundtable discussion and for tackling as many questions as we had time for from attendees. I certainly want to thank everyone who took the time to join us today. And with that, this concludes today's webinar. I wish everyone a wonderful afternoon and a terrific weekend. Thank you.